So Colorado Mad Moms is a grassroots organization of parents, family members, and caretakers of persons living with severe mental illness and their allies. The Colorado Mad Moms vision is that people with serious brain illnesses in Colorado be treated with dignity and respect, receive person-centered, equitable, compassionate, evidence-based care and support. There is a sign-up sheet at the back of the room, and if you would like to be included in their updates and work, you can sign up there. Our program will begin with a medical lecture from Dr. Rob Laitman, followed by a brief break from 10 to 10:15. After the break, we'll watch the documentary Into the Light and then close our session with a stand-up comedy performance by Daniel Laitman. My name is Elizabeth Almond. I'm a family nurse practitioner here at Vista and medical director, a nurse of 24 years, and the proud mother of a beautiful young man who fights schizoaffective disorder every day of his life. As a medical provider, I received almost no training in mental illness and virtually none in severe mental illness. The message I did receive was that there was little we could do. And as a mother watching the suffering and loss my son endured, that dismissive attitude was something I simply could not accept. When my son, now 22, first developed schizoaffective disorder bipolar type in 2020, as a family, we braced ourselves for what appeared to be inevitable, losing him to the streets, to suicide, to addiction. We watched in horror as our son disappeared before our eyes, despite every last penny spent on the best care we could find, repeated calls to 911, ED visits and hospitalizations, multiple medical providers, and more medications than we could count. This changed when I ran into the work of Dr. Laitman late one night. Dr. Robert Laitman is a psychiatric internist dedicated to transforming the treatment paradigm for psychosis. He is the author of Meaningful Recovery from Schizophrenia and Serious Mental Illness with Clozapine, a book that chronicles his family's personal journey, supporting his own son, Daniel, through schizophrenia, while pioneering a novel, evidence-based approach to treatment with clozapine. I stand here as a living example of how his work has impacted families around the world, offering a message of hope where families like mine were told there was none. Dr. Laitman's approach has fundamentally changed the trajectory of countless families facing severe mental illness. Many of you are familiar with the disability rights mantra, "Nothing about us without us." Dr. Laitman and his family embody this principle. They bring not only clinical expertise, but a deep understanding of lived experience, the daily realities, challenges, and hopes of those impacted by severe mental illness. It is my honor today to welcome Dr. Robert Laitman.
Hi guys. Oh, and by the way, pay attention. There will be a test on this, and you're going to be presented with a lot of information. Hopefully, there we go. And don't worry about it. It's really very available. In fact, I'm going to make a little plug before I forget to make the plug. I'm sure going to make a few plugs for it. But the 5th edition of the book is out, and it has all the slides that are here. That I'm going to present today, and many, many more, and it just has a lot of information. If I get this to go, there we go. So, again, thank you for the introduction. This is really very personal, and very personal for many of you people that are out here. And my contention is, much better, that there is actually a correct way of taking care of kids with psychotic illnesses. And it all starts with, I want to start with my view, because as I said, it is really very, very personal. This is, I self-titled, and that is a self-title, a psychiatric internist. I kind of made that one up. I'm really just an internist. I'm trained as a nephrologist and a gerontologist, but my life changed about 20 years ago when, I was faced with serious mental illness. And the reality is I should have kind of seen it coming. I had a grandfather with schizophrenia, an uncle who was top of his class at 2,000 student class and developed schizophrenia and lived a very diminished life. And an aunt who had bipolar illness with psychosis, but was one of the first people ever on lithium and had a full and productive life. Even as a kid, I was not a bad student. I was top of my class until my junior year of high school, when I had a dramatic downturn in my academic. And, my father was a clinical psychologist, and in fact practiced till he was 96. Just missed the boat. I was sick my junior year. I went from straight A's to straight C's. And I got lucky. For me, and this is part of the name of our charity, I just had a really bad year, and I found the solution for me was running. And I started to run after my junior year, and I've run for the last 40, I guess, so how old am I now? Last 50 years or so. And I've run 120 marathons, I've run the last 27 Boston marathons. But for me, running was the answer. I went back to being, a near straight A student. And what was that when I was growing up? In retrospect, I never needed much sleep. I was always a little bit impulsive, often difficult to work with. Wouldn't take no for an answer. So what was that illness that I had? Probably in full retrospect, I was fortunate to, have a depressive phase of a bipolar illness that never progressed beyond that and kind of left me in a chronic state of hypomania, which I've maintained with running 50 miles a week. So then my son was born. My daughter, he was very different from the get-go. My wife is also a physician and really co-partner with everything we do. And he was different from the get-go. And we knew there was something up. We didn't know what. We were both very busy. We then subsequently had 2 more children, so there's 4 of us. So we're going to try a different mic. Oh yeah, there we go. I'd like to sing a song. No. So, let's see. There's my boy. So, again, every time you see a homeless person in the street, think of this picture, because that's where they started. They all have parents, they all have family. But Daniel was a mush, and he was very, very different. Whereas my daughter was saying the Pledge of Allegiance before she was 2. But Daniel was different. He, carried a number of diagnoses going up. And we had him seen by a psychologist and a therapist. And he would go into the therapist's office, and we'd say, what's going on? And he would say, I can't really share privacy rights. And a 6-year-old, really? What are you guys talking about? So nevertheless, life went on. He was started on a stimulant for his ADHD, something I would never advise you to do now, given especially the strong genetic background that he had. But things carried on, and he managed, with support, with an IEP, individual education program, until it didn't. And this is age 15. If you look at this picture, it's blurred. And I didn't purposely blur it, but it's appropriate that it's blurred, because so many times when your kids present, you say, what is this? Is this just teenage stuff? What's going on? It's not clear. So one of the things I tell my parents is always, check the blame, check the guilt at the door. These are not easy things to figure out, especially in the beginning. But with Daniel, it was pretty easy. You see how his arm is? There were voices telling him to hold his arm like that at that point. And we were on vacation in Canada, and he would walk back and forth quickly. And he was just different. And we knew that there was something else. We came back, this is sophomore year of high school. We started him, during the summer we'd take him off his ADHD medicine and also his antidepressant. And we resumed those when he started back in school. And within 2 days, the light was gone from his eyes. He was just no longer our son. At that point, I still get teary about it, but at that point, we brought him to the psychiatrist who said, yes, he's hearing voices, had been hearing voices off and on, but she didn't think much of it and didn't decide to tell us. And that began our journey into psychosis care. Subsequently, he was on 5 different antipsychotics, 3 at the same time, all with bad outcomes. Now, this is where serendipity comes in and luck. I got a call from my in-laws saying I have to talk to this woman, Deborah Levy. But again, they were my in-laws, so I didn't pay much attention. But a week later, my parents called, total different connection, and said, you have to talk to this woman, Deborah Levy. So Deborah Levy was the head of the McLean Hospital, which is the Harvard Hospital for mental illness. She was the head of the psychology research lab. And we went up and met her. This is 6 months into Daniel's illness, and said, this is crazy what you're doing. Your son needs clozapine. Let me open up the library, the Harvard Library to you. You read for yourself. And the evidence, and this is 20 years ago now we're talking about. This is 2005, 2006. The evidence was already overwhelming that if you had failed 2 antipsychotics, you should have been on clozapine, and people were not following evidence-based. So I begged for clozapine. It wasn't going to be that easy. It took me 5 practitioners. Lou Oakler, who was a co-author of my book, wasn't taking new patients, and that was a mea culpa till the time he passed away a few years ago. And he wouldn't take care of Daniel because he was overwhelmed. But he also agreed with us that he needed clozapine. It was just finding someone to do it. And one of the things about being a physician is you're never supposed to take care of your own family. But being who I was, I'd already been taking care of my mom and dad since I was out of medical school. And they lived to 99 and 101, so I didn't do too badly with them as well. And it was convincing my wife, who was more traditional and not as, I guess she's a little more neurotypical than I was. But eventually we took over Daniel's care. And we were shocked that no one had written about clozapine. 60 years it was out, right? There hadn't been a book written about it that I knew of. Actually, someone else I met on my journey, a gentleman by the name of David Taylor in England, had written a book in England, but no one would buy it, and it went out of print with less than 100 copies sold. So, this is Daniel now. This is after 18 plus years of talking. This is actually a few years ago. All these slides are a little dated. I apologize. But Daniel, who we were told his life was over, and I'm sure some of you guys have heard this, is, in fact, when I went to my first NAMI event, I was told to mourn for my child and then lower my expectations. And I just found that a really nihilistic and inappropriate answer.
Yep.
And especially as I kept reading about what was known, because so much of this has been known for such a long time. That's what's so incredibly disappointing about all this. This is information that's been out for a very long time. It's just never been synthesized and put into one place. And, and the mantra was that there was this tremendous fear about using, the most effective medicine. So Daniel, nevertheless, whose life was supposedly over, went on to graduate from college on the dean's list, Phi Theta Kappa, started a stand-up comedy club, which, again, most people with schizophrenia are stand-up comics. Very interestingly, Deborah Levy questioned the diagnosis, the head of the psychology research lab, because even her, she said, he's funny. He can't have schizophrenia. Again, the nihilism, it was just so pervasive. So looking at it, not getting any formal training and just reading what's out there, I said, this is just not right. This is not appropriate. So Daniel, for the last 10 years, has lived in the city independently and has a decent career. We still supplement him.
and thank you, Kate, for supplementing him as well. And he's finally embraced after all these years that he's a little unusual in this community, but it's nice to see someone with serious mental illness, with quote-unquote schizophrenia, which is supposed to be a neurodegenerative illness, right? That's what you're told, where you lose your cognitive abilities, be able to be facile enough to interact with the audience, memorize 30 minutes of material, and deliver it. You can hear me talk, but I think seeing it is, as you said, believing it. You're going to hold the questions till the end, my dearest Maria. So, again, and also, what else has he done? He just got married. So anything is possible. I've been to a few weddings, and I've also been, not to the childbirth, but seen children's products of people that are on closet. Again, none of this is easy, but it's doable. So what are these illnesses? They are, ready, heterogeneous, which means there's a lot of variety here, complex, so complex genetic, and they are a spectrum of illnesses. You just have to be, and they're very much, in the vast majority, neurodevelopmental. But when people talk to you about absolutes, when you're talking about psychosis, there are no absolutes. That's the only absolute that there is. There's so much heterogeneity in the expression. And this is an old slide, and there's actually now over 300 identified genes. So this is Manhattan Claw. You see the really tall one? That's an expression for complement C4A. And that is something that you use in your immune system to identify what needs to be removed. It so happens that if you have that gene, you'll take whatever baseline risk you have and increase that risk by about 25%. And it also speaks to one of the mechanisms why clozapine may be so much more effective, because it does have that immunologic properties. It does dampen down the immune cells in your brain, something called the microglia, from overpruning. At least that's the thought process. And it does it, at least in rats. In humans, we don't have the in vivo data. We have suggestive data. We have autopsy data. We have MRI data. But again, it's all indirect. But nevertheless, so if you look at all these genes, interestingly enough, what do they express? They express different parts of your brain. So of all the genetic machinery that you have, all the genes in your body, about 50% of them go to develop a brain. It's amazing that, any of us are neurotypical, and probably if you're here, you're not. But everyone is different, and we all share these genes, and therefore expressions of neurotransmitters, synapses, the glial structure, the development of brains. Again, there are trillions, not billions, trillions of connections in your brain. So there's lots of things that can be going on. If you ever watched a brain develop, you would be shocked that any of us come even somewhat close to being able to walk and talk at the same time. So this is like one of my all-time favorite slides. And it was supposed to be the clinical course of schizophrenia, but I put this up here to stress what is going on in a lot of your kids' lives. So again, these illnesses start in utero, very typically. For instance, Anne had gestational diabetes, did not have that with any of the other kids. So we had an additional stress because she did have some low blood sugar episodes during that time frame. Certainly we know kids born in the winter have an increased risk of psychotic disorders. We know that people that have had the flu during their pregnancy, especially the first trimester, also have that, as other variety of illnesses. So don't be terrified to be pregnant, but get your flu shot and everything else that you can do to avoid these illnesses. But they start early, and it's in the polygenetic risk score. What happens is, very early on, you'll have connections that are different, and often you'll notice something about these kids, like with Daniel. They are different. They can be clumsier, they can, be a little bit slower than the other kids in your family educationally. Then again, they can look just like everyone else. But what will typically happen before you have what we call the overt symptoms of psychosis, and what is that? That is the positive symptoms, when it becomes so apparent, when your kid's delusional and hallucinating. But before that, typically, you develop what are called negative symptoms. You start to have some cognition. The kid may isolate a little bit. The kid may start not to do as well in school as he had done. He may, shy away from some of his friendships. And, so you'll bring them maybe for evaluation and say, it's immaturity. We got that. Or it's attention deficit. And all the time it's a prodrome. A prodrome is a description of something that is before the full-blown illness, but it is part of the illness. And you'll get different diagnoses depending on where it is. Let's say he is feeling stressed and more insecure in a social relationship, and he turns to pot. Well, that increases his risk of going into full-blown psychosis by 5-fold. You'll bring him in, he'll hit the emergency room, you're told that your son or daughter has psychosis secondary to cannabis. Is it wrong? No. That's what they know at the time. Let's say you get lucky and the kid stops cannabis. Well, a third will still go on to develop psychotic disorders. So that is a harbinger, but not necessarily destiny. Let's say they get stressed in school. They stay up all night. They start making bad decisions. They think they're Tutankhamun, king of the world. Now you're told your son or daughter has a bipolar disorder. They're given an antipsychotic, the stress goes away, they return to their pre-morbid condition. Time marches on. So the problem is, what are they usually treated with? They're usually treated with they're treated with antipsychotics, mood stabilizers, and the typical antipsychotics. Often they are withdrawn because your son or daughter tends to get better. Well, time goes on, there's still a mood component, but then they get psychotic again, and they say, there seems to be something more pervasive about this. This is a thought disorder. But there's a mood component. So what do we call it now? Schizoaffective disorder. They get treated again with a typical antipsychotic. The illness continues on. The negative symptoms continue to accrue. The neuroinflammation, the ongoing process, continues. The mood component kind of dwindles away, or it becomes not necessarily as important in terms of their psychotic illness, and the psychosis becomes pretty much around the clock. And now what do we call it? Schizophrenia. It is just the same illness. These are psychotic spectrum disorders. And it's not a one-way street, guys, because I've taken people that have gone down that whole avenue, and now 10 years later, because they like it, and it's easier to date, we'd say, you just have bipolar illness with psychosis. It was schizophrenia before, it was really a thought disorder, but you're 8-10 years later. So it doesn't have to be a neurodegenerative illness. It can be something that you can impact. You just have to be very patient. So what is psychosis? You got to understand what psychosis is. It's not just the positive symptoms. It's not just the dopaminergic stuff. That's just the stuff that jumps out at you. That's the ability to see something called salience, the ability to know what is real and what is not real. Is your brain uses dopamine, which there's not a lot of dopamine in your brain, but it's used critically in certain areas of your brain to identify what's real and what's not. And so you get dopamine dysregulation, and you get the delusions, the hallucinations, the bizarre movements, the bizarre speech, sometimes word salad at the worst. And at the very worst, you can get catatonia, where you're so internally directed that you're totally detached from reality. People don't talk a lot about this, but there are different domains. And I purposely add the mood component because that is often such an important part of the domain. And the hopelessness that so many of these kids get, and the suicidality, which is my ultimate fear. You have to address all of these things. But what is the thing that really, besides suicide, obviously, that's going to impact your child, that's going to determine how well they're going to do in society? That's dealing with the cognitive symptoms and the negative symptoms. You know, the ability to get started, the ability to express joy and appreciate joy, having more of a full affect so that you relate better, you know, being able to be social. And those all play in to the cognitive deficit, because if you don't have good processing speed and able to switch on and off, because we don't do two things at once, we do one thing at a time, and we go one thing to another. Part of this illness is a decrement over time in processing speed unless you take care of the pathophysiology of the illness, unless you're impacting the illness. And that means very good control of the psychosis. We know, and this is a quote from Henry Nasrallah, a gentleman out in Ohio, so I won't take credit for him, but he says, psychosis is like a slow-moving stroke. And basically he says you lose about 1% of your brain. It's interesting, you don't initially lose the actual neurons, but you have a slow decrease in connectivity, and you're losing connection over time. And that leads to slow processing speed, decrease in long-term, short-term, and working memory, executive function decline. Brush your teeth. Please brush your teeth. God help you. Please take a shower. You know, all these things become exceedingly difficult over time unless you address them. I put comorbid substance abuse in because if you actually look, and Daniel, interestingly enough, though he did have one at his beloved Bucks Rock camp, one pot brownie, which he didn't know about until he took it. And he had the same response that I had, because I'd only done pot twice in my life. And I got paranoid both times. And I said, you know, first time I did pot, I said, bad pot. Second time I did, I said, no, pot's not for me. And it's interesting, my sister had the same exact experience. Daniel as well. So we have that gene as well, lucky us, which is, we can talk more about pot later. But nevertheless, 85%, if you're going to include alcohol, pot, other substances, and cigarettes, 85% plus of kids that develop psychotic disorders have comorbid substance abuse. And it needs to be addressed. You know, and the old way of addressing it was, there was an initiative from Marlboro called SCUM, called Suburban Cultural, you know, something or another. But that was the acronym, and I forget what it, for mental illness. They would go after the people with mental illness because even though it represents only 3% of the population, people with serious mental illness smoke 50% of all cigarettes.
Wow.
That's a lot of cigarettes.
Wow.
And they used to back the trucks up to the institutions and just give them the cigarettes. Again, nicotinic receptors are really important. You need those for what we call gating, the ability to filter out extraneous information and concentrate on what you want to concentrate. People that have smoked notice that it kind of tends to calm and then it gives you ability to focus. My parents, all, I mean, that generation, the greatest generation, they all smoked. And, you know, during the war, if you wanted to live and you're, you know, patrolling, probably not the worst idea in the world to stay alert. But again, our group, it feeds right into that. This is the domain that probably, I just added, but probably the one that impacts so many of you so much of the time, and that is the unawareness of illness. This is a reflection. It's really not a separate domain because it really is part of the cognitive and negative symptoms. But our kids, even though we want them engaged and we respect them and we want to be patient-centered, often are the worst arbiters of their own care. And in psychiatry, this is why I just call myself now an internist taking care of psychotic illnesses. I kind of force myself. No offense to any of the psychiatrists in the room, because there are good psychiatrists, obviously. But we ran into the trouble where, they won't talk to you because of the release of information, right? And that is where the rubber hits the road here, is where you have someone you're trying to get help, and the practitioner won't talk to you. And that's because of this. These kids just don't recognize that they have the illness. And it doesn't have to necessarily be even that. They don't recognize their own limitations, and they also often are really bad evaluators of their own talents. I was relating last night, Daniel, great set, best comic in the world. Bad set, worst comic in the world. So my son does this to this day, just loses that bit of information. And what they do, and this is part of the illness, a lot of our kids have trouble synthesizing outside stimulus. It's much easier to live in your head. The connections are easier, they're more pervasive. So that's why you never try to talk someone out of a delusional belief. It's a fixed, false belief. And it's real easy. The neuroconnectivity is there. It takes a lot less energy. So they have they're very concrete often. And as I said here, like talking to a wall. And this is all part of the anosognosia. And what happens with all this? Anosognosia, as I said, meets HIPAA. Health Information Portability and Affordability Act, 1996. Incredibly well-intentioned. We're just at the start of the information age, basically. And it was an act, it's a several hundred-page act to really protect your information. And it is one of the, if not the most misinterpreted acts. There is a typo here. As long as the healthcare provider, I missed an L there. But the bottom line is, your healthcare provider can use best judgment. And if in their best judgment, they feel that it's warranted, if they understand what psychosis is, they should feel it's warranted, that they should talk to your loved one and involve them in all of this. And has there ever been a prosecution when someone has done that? In other words, to the best of their ability, using their best judgment as a physician, as a nurse practitioner, no. The only prosecution has been when a gentleman in California went to the psychiatrist and said, I'm going to kill my mom. And that psychiatrist decided not to tell. So it doesn't go the other way. Judgment. And you should not accept this. And you should show this to your healthcare provider if they give you a hard time about this. Okay. So again, the onset of psychosis. Now what I'm talking about again is that, again, the dopaminergic system, the delusions, the hallucinations. And this is a treatment, right? So the standard treatment is with dopamine blockade, D2 blockade. And that's always been the standard. And all of the drugs are designed to block D2, except for a new drug, which was derived from some of the action of clozapine, something called Cobenfy. And we can talk more about that later. But it's not a big player. I can talk more, but it is not a big player. You block 60% to 80%. It doesn't mean that their psychosis will resolve, but in most kids, it does do something. Not all, but most. So even early on, about a third of kids will have no response at all, a third to a quarter. And those are the kids that absolutely have to be on clozapine. But most will show a response and will get better and may not look like your kid was before the psychotic illness, but clearly is better. Clozapine also does bind D2, but it kind of flits on and off at the lower levels. I explore much higher levels, and it does bind more so in that setting. And there's another class of drug, it's called the dopamine 2 partial agonists. They work also by binding dopamine, but as opposed to 60-80%, they bind 95% or more. One of the common errors that I've seen is that people will add, and these are aripiprazole, cariprazine, and brexpiprazole. Those are the three in this class. Will add that drug to be adjunctive to whatever other antipsychotic, by the way, not evidence-based. In fact, if they understood the physiology, they would realize that they are kicking the other antipsychotic off of its dopamine 2 receptor. I was at and believe me, people don't know this, I was at Schizophrenia International Research Symposium in Chicago, and there's a lovely woman presenting who was a physician from England with Dan Siskind, who's one of the leaders in schizophrenia care and clozapine care for that matter. And he's relating how they get past the prolactin problem. Because if you block D2, your prolactin levels go up. And this woman was having milk coming out of her breast and found that discomforting. So the teaching in psychiatry, which is, interesting because this is still in the guidelines, is to add one of these partial D2 blockers, aripiprazole, because it's not as associated with prolactinemia. So I quickly raised my hand. I go, oh, so you did that, and then you got psychotic, correct? And she said, how did you know that? And I go, that's the neurobiology. What they did made little sense. Well, if you're having this issue, what's the one drug you could have gone to that is not associated with elevated prolactin? Anyone in the audience? Clozapine. Right. Which is what she eventually did. Okay, so these are all our lucky winners, and this is where psychiatry, and if you're taught this in most med schools, this is where they stop. It's so infrequent that clozapine, 20 years ago, was mentioned. It's getting better. It's definitely getting, as it's reflected by this crowd, because when I first gave this talk, I'd have 8 people in the room. So people are starting to get it. So, you've heard this. It's good enough. Your kid is not trying to kill anyone. He's not trying to kill himself. He seems to be relatively well entertained in your basement playing video games. Okay, so you're going to support him the rest of your life. Put him on his disability. Accept this. He's going to have a diminished life. Maybe you'll get lucky to be a cashier somewhere. Work 10 hours a week.
Calcium and lithium.
All sorts of things. So, why is that? Because the D2 blockers overall don't touch the cognitive, don't touch the negative symptoms. And those are what impair you. In fact, over time, they tend to make them worse. We could do better. So how do we do better? Now, we also have this conversation, I'm trying to be realistic. The one thing clozapine does not have is a long-acting injectable formulation, and it never will. It'll have, we're actually working on developing a implantable clozapine, but it's years away. And if anyone in the room knows a billionaire, please contact me. It's not for me, it's for my friend David Taylor in England, because we need money to develop this, because we don't get a lot of pharmaceutical or support because it is a generic drug. So we don't get money. But it is something that we can develop, so we can have it implantable. So when you have someone who you cannot engage in any other way, you're going to have to turn to these D2 blockers. My objection is that you just stay with them. I think of them more as a bridge. If you can get them reasonable enough that they can then be in a position where you can then engage them, then you can turn to clozapine. So this is my approach. I believe, and the data is overwhelming, that we don't turn to clozapine early enough in the treatment. The average length of time after someone develops a psychotic illness in the United States is now 8 years before they get clozapine. 4 years is typical after they've already demonstrated by all clinical criteria that they have a resistant form of psychosis. And clozapine is not only for schizophrenia, it's for any form of psychotic disorder. People are terrified of clozapine. I'll tell you why. And that brings us to the assertive managing. Learning the drug, learning how to approach it. You guys got to do the medicine and not following what's in the PDR. The physician desk reference has a statement of how to titrate and use clozapine. And it is based on my friend, who actually is my friend now, Gil Honenfeld, who is the original champion of clozapine, who brought it back after the 1975 incidents where clozapine came from 1958, was developed by a guy by the Hippus, and it just went into development and was really showing a lot of promise. In 1975, 18 women in a small Finnish village developed something called agranular psychosis, which is very low white count. And of those 8 people died. It went off the market. And people thought, oh my goodness, this is going to happen in a frequent amount. We've never had anything like that since. And as it turned out, these women tended to be older, tended to be on other antipsychotics and other mood stabilizers, including Depakote, that were associated with severe neutropenia. And there was also, it looks like, and this is not conclusive, there are certain genes that could predict, with as opposed to the very tiny risk of developing the severe neutropenia, but there was a heightened risk in that certain population. So a lot of bad things happened. But nevertheless, Gil Honenfeld saw this medicine, and again, it was personal, because he had a kid with psychosis as well, and worked with Sandoz and resurrected the drug. And in 1989, they did a landmark study showing that it was where nothing else worked. So they had taken 3 drugs from 2 different classes of antipsychotics, given the kids 60 milligrams of Haldol, which is an enormous dose of Haldol, then gave them, Thorazine versus clozapine. The Thorazine group, done, nothing. Clozapine group, there was a good recovery rate. Not great, 23%. But getting back to the PDR, the drug company only gave them 6 weeks to do the study. Can you imagine getting up to 400 milligrams or higher? They took it up to 600 to 800 milligrams in 6 weeks. So, and in that setting, it was remarkably superior. But unfortunately, what the PDR did is took his titration schedule and engraved it and put it in. And that's totally inappropriate. Jill knows it's totally inappropriate. Anyone that uses clozapine knows it's totally inappropriate. Way too fast, way too many side effects, and all very easily avoided by just going slower. And then the most important part, you have to have engagement of the family and the kid. If you're going to do clozapine, you need support. This is not someone where you say, here, take the pill, see it. The worst thing you can do is I know, multiple layers. You can never be warm enough. But the worst thing you can do is start someone on clozapine and not give them support. To come on and off. Because even though it's by far the most effective treatment that's out there, the rebound's the worst. So not only you get the rebound from it being such an effective antipsychotic, rebound psychosis, but you get what's called cholinergic rebound, because one of the properties of clozapine is it's very anticholinergic, and that's just horrible. So you need engagement. So what are the early intervention? Again, this is American Psychiatric Association guidelines. Fail to start. And it doesn't have to be long, 2 to 4 weeks. You know, we should be starting this really early. This is treatment resistance response in psychosis group. I'm actually part of that group, so I should know what it stands for, but I always forget. And, you know, we came up with, and this is back and forth, I wanted shorter time. But 6 weeks is kind of reasonable, and with good compliance, you're clearly not responsive. And then there's been a number of studies. And this is where I'm going to put in Cobenfy in, I'm going to throw this in, because we know that if you fail one drug in the United States, the chances of any other drug working is less than 5%, except for olanzapine, and that was a study with 29 patients, so fall up to 7% because it was 2 patients that responded. Aspire is a study that just came out. I think it's Aspire. Doesn't matter. But it's a study with Cobenfy added on to people that were not fully responsive to their other drugs. They just completed this at a year. Anyone want to know what the response was? Probably haven't heard about the study. It's not got a lot of press because it was a negative study. It really didn't help. So in other words, you can also say, and this is with the other drugs still on board, but in a resistant population that is not responding like you want, Cobenfy, xanomeline, trospium does not improve the outlook. It was a pretty big study. We're doing another study with a guy by the name of Rubio and John Kane at LIJ because they spent how many billion? $12 billion, I think, Bristol Myers Squibb, buying the rights to Cobenfy. Karuna Pharmaceuticals they bought. And I know the guy who's, you know, 'cause he's been talking to me about this drug for years. And I said, yeah, it's an amylase. It sounds interesting. Maybe it could be adjunctive, you know, because of its properties that, by the way, and the drug was derived from known actions of clozapine. Clozapine is so different because it does hit D2, but it hits all the other. Remember that slide I showed you with all of those different genetics? That's what clozapine does. It's anti-inflammatory, it hits the nicotinic receptors, it hits the muscarinic, it hits the GABA, hits the glutamate, NMDA, the serotonergic receptors. It is what we call the ultimate dirty drug in that it has multiple receptor systems. Do we know how clozapine works? Hell no. I'm honest. We understand the pharmacokinetics, and we understand the receptor systems, and we understand what it does in the brain. But since there's so much heterogeneity in the illness, for any individual, clozapine's going to probably work differently. It depends what you got. I'll give you an example. Daniel, we really remarkably better with clozapine, but wouldn't read. We decided, there's some literature. Herb Meltzer did a study, there's 14 patients in it. He called it a negative study, but I read the study and there were 7 patients that actually had a dramatic response and 7 patients that did nothing. And it was to donepezil, an acetylcholinesterase inhibitor used with Alzheimer's. And what the hell? You know? Clozapine is, I'm a big tinkerer. And Daniel was people who read the book, my N of 1. So I said, I'll give Daniel some donepezil and see what happens. And lo and behold, he read. And started reading, has been reading ever since. So for him, the nicotinic receptors, the cholinergic nervous system is very important. Done this with other people, just like Herb Meltzer, not much happened. Helps a little bit with the side effects, but that's beside the point. Okay, so again, a big problem, and this is don't get bent out of shape by 0.4. Because again, that was one study done in Japan by a gentleman by the name of Yamahara, and it only had 28 patients in it or so. And, and he also only followed them out for 2 to 3 years. So what he found is if you start things earlier, he had a response rate of well over 80%. And then if it was 3, 4, or 5 years out, those response rates diminished to less than 20%. But he also only followed them for 2 years. Our experience, because I have now 20 years of experience with this, and between my wife and I, and if you really want to include all the other people that we interact with, because we hear about so many people now, we're getting towards, we're north somewhere of 400 patients. It just takes longer. You gotta be patient. You gotta be so patient. So part of the S, you can also say is slow. And again, why do you want to start early? Well, what's the big risk? Early on, 50% of people with psychotic disorders, and that's on the high side, 40 to 50%, depending on the study, will at one time contemplate and attempt suicide. 3, and these numbers are a little too high, I think, 3 to 5% will complete suicide. What is the only FDA drug of any kind that has the FDA indication for suicide prevention? Anyone? Oh, you guys are paying attention. Clozapine. And it reduces the risk by about 90% compared to all the other drugs except for olanzapine, whereas 23%. This is again, Herb Meltzer, I'll quote him again, the Intercept study in 2003. We've known this for a very long time. So it's not only for resistant schizophrenia, again failing other drugs, it's with persistent suicidality, which affects about half of our kids. This is real recent stuff. This is my friend, again, another friend. She runs from me still when I see her. Heidi Taipel from Finland. The Finns and Norwegians are amazing people because they actually have a national healthcare system and a national database. So there is no cherry picking. You get everyone. If you have a hangnail, you're in their system. So they've been following over 20 years 62,500 people with psychotic disorders. And what they found is if you look at kids and they are treated with an antipsychotic, it reduces the risk of having another relapse. In other words, and how they define a relapse is necessitating a hospitalization for out of control psychotic behavior or suicidality. If you stop the antipsychotic, that increases your risk. If you have them on another antipsychotic and they have another episode, and you give them any other drug but clozapine, it does not seem to help. In other words, they've shown already that early resistance. And clozapine dramatically reduces the risk of psychosis. This is the first episode. This is the first year or two of treatment. And also, if you switch off of clozapine, you double the risk of hospitalization. All right, we're going to do a lot more about the assertive management. This is the part I added, the second hour of the talk almost. But you got to do therapeutic drug monitoring. Clozapine is a drug that you really have to understand, and I love pharmacology, so for me it's a great drug. I mean, I'm a nephrologist, I live with pharmacology, but it's a fun drug, but it's got a complicated metabolism, and it really is dependent on, primarily most people are 1A2, but 3A4, 2D6. Those are the three major players, but it's really 1A2. And you really, it'll be different. So someone who is a white, male, slender cigarette smoker will have a different level compared to a Southeast Asian heavy-set woman who's not a smoker by as much as 9-fold. So it's not just, oh, this is the dose, we don't do levels. That's, can I curse a little bit? Okay, that's bullshit. That's just bullshit. It's wrong, and if you're going to use clozapine, you have to do therapeutic drug monitoring. And also, you have to do it because if they get ill, what happens if you, let's say you develop a pneumonia and you're on clozapine? Well, if you think about it, you want to, if you have a pneumonia, you basically shut down anything that your body does not need to fight the pneumonia. And that includes shutting down your metabolic pathways. And clozapine with pneumonia and with COVID will, in severe cases, triple. So you can take a kid who's rock stable and they develop pneumonia, their levels, let's say you're 600, they'll go to 1800 and they'll be toxic. And you have to know that. And you have to do the levels. The problem is sometimes you don't get levels back fast enough. A quick and easy way of doing that, just a little pearl, is you follow HSCRP, high sensitivity C-reactive protein. It's a reflection of the inflammatory proteins that are in your bloodstream that essentially shut down your 1A2 pathways. So you get gross elevation. So I always, baseline, we'll talk a little bit more about that. I always get to see where these people are. Because a lot of these kids are chronically inflamed. They run elevated numbers on the low side. But you get grossly elevated numbers, you know right away you better shut down the clozapine. You've got to go, I routinely with pneumonia will go to a third of the dose. So really assertive therapeutic drug monitoring. You really have to be a doctor. Now this threshold, again, 29 patients was in that study as well. 350 is just what everyone comes in, you know, you're gonna get that on your little form when you get your clozapine level. But the reality is, if you have a less pervasive illness, and I use this with bipolar, I use it with schizoaffective, I use it with schizophrenia, these are all spectrums of illnesses. But what it does tell you, my bipolar population, my mean levels are in the 200s. Whereas my patients with schizophrenia, my mean levels are in the mid-600s. So that's a very artificial number. It gives you a guideline. In that one small study, what they found is about 2/3 of the people started to respond. But what the mistake that I've often found, and what a lot of people have come to me for, is failures on clozapine, is people stop there. There is increasing efficacy all the way up. And 1,000 is a conservative number. You have to monitor and go after the side effects, which brings us to point 4, because they do get worse. So with efficacy, unfortunately, comes some toxicity. But it's manageable. And sometimes you need these levels. So you have to, and I'm going to keep saying it, do the medicine. You can manage all of these side effects. And we'll show you around. And then, again, what's kind of cool is I tell people, clozapine does not make you better. It makes your brain better. Then you have to do the work. You have to do the recovery-based therapies. You need to do the cognitive behavioral therapy. You have to do the cognitive enhancement treatments. These are all evidence-based and really productive approaches. If I had my way, I'd have them all running marathons with me. But diet and exercise. And then the cool thing is, they do it because they're better. They can now participate. My son used to break down when I used to get him on the treadmill. He wouldn't exercise. And on clozapine, it changed. You know, I think he's run 8 half marathons now. And we're doing another one in January. Slow. I can't emphasize this enough. So when you're on something else, which I'm sure many of you still are, one of the common mistakes is, oh, we're going to stop this medicine and start clozapine. That's wrong. You add clozapine to the existing drug. If the kid is failing, you don't take away something that's partially working, because you're going to have to go up slowly with the clozapine. So I've had also failures where that's happened, where they just take away the medicine and then start 12.5 milligrams of clozapine or 25 milligrams, or try to go very quickly. And it's a failure because it's not done correctly. You want to take your time. So in our hands, you know, and if you go back and look at some first episode psychosis trials, there's about a 50% dropout, and that's fairly typical with most clozapine because they use the old titration schedule. We've had less than a 10% dropout in our patients using our approaches. So you can engage, you can maintain. And you can do this for the long term. Also, the claustrophobia, the fear of clozapine, often will center around the neutropenia. That is also felt to be an immunologic phenomena, and it's often dependent on the rapidity of the introduction of the drug. In the Netherlands, at Johns Hopkins, and in our experience, and that consists of over 2,000 patients, we have not seen any myocarditis or neutropenia because they all go slow. Raphael Schulte, guy in the Netherlands, on his own came up with a very similar protocol to mine, and we kind of embraced each other at one of the meetings. But I get the credit, because I was first. Published. But you don't see these things. You go quickly. You go to Australia. They still do the rapid dose titration. You see an incidence, and they also over-monitor, and they call myocarditis a slight elevation in what are called serum troponins, which is an enzyme released by the heart when it is damaged. And they call it at very low levels. They cite an incidence of 2% or so. Again, in the Netherlands, all experience, because there's more than just Raphael doing it there, it was, I believe, 0.2 or so. So 100 times as low. So what do? We go slow. It allows us to use the lowest doses that we need. And I explore. I'm a huge tinkerer. I have a lot of trouble staying put with something. I always think I could do better. So I play a lot, probably too much. But I'm always exploring and seeing where I can get someone. But I go slower. As they get better, I slow it down. I go to a crawl. If I think someone's really good, and I think they might be a little better, and I'm looking at their levels, and they're not that high, and they're not that sedated, and they're doing okay, but I think there could be more to be gained, I'll go by 12 and a half. And I'll say, see you in a month. See what you think. Get a level. Maybe go up another 12 and a half another month later. And explore. They will tell you if you go too high. And you'll see it as well. Don't short sell the drug and learn to manage the side effects. But as I said, when you start, I start at 12 and a half, and I go up every 3 days when I'm starting. And I usually don't touch the other drug until about 100 milligrams. But depends, again, if I get that very slow metabolizer, the Southeast Asian woman, I will usually check at 50. Or if I see something that looks untoward, like there's a lot of sedation early on, I will check levels earlier and start down on the other drug. So there's always flexibility in this, except for going slow. You got to go slow. You have to be patient. And then the engagement. I use everything I can. Certainly I've used Javi. You guys have all read I Am Not Sick, I Don't Need Help. Everyone? Amador. Javi Amador is the lead. Listen, empathize, agree, partner. Great conceptually. It works to a certain extent in a lot of people. Basically, befriending people is essentially what it is, which is all I do because I don't pretend to be a therapist. It's helpful. But when you have someone really fixed, really delusional, really paranoid, really uncooperative, who's not going to engage with you, you shouldn't be afraid of using court-mandated treatment. I've had kids throw things at me, threaten me with a hammer. I've had 2 police interventions. It's not pretty in the very beginning sometimes. But now they run with me. They call me my friend. They text me. They let me know when they have their job. Our success rate I've done 18 of these assisted outpatient treatments. It's not a vindictive thing. They will not hate you for it. They will thank you for it because it'll allow you to treat them. And a lot of these programs, and I don't know what the program is exactly in Colorado, but it sounds somewhat similar to New York, where they're not only given, a court mandate to take the medicine, but they're given a team of providers to help. And it's great in theory. In reality, it's not so terrific because we tend to underpay all of our workers and the turnover is enormous. But even after all that, just having the court, the black robe effect is very effective. So you need to engage. You can't use philosophy unless you have engagement. And I really think that the vast majority, because there's always exceptions to the rule, will not get their level of recovery unless you use philosophy. It's just so much more effective than the other drugs. And again, don't let HIPAA stop you. And the one thing that really is about engagement is community. And that's one of the things that we really stress and where I came from more my dad than anyone else, because my father was a big believer in the other economy, the barter economy. Like I got my tennis lessons from a patient, we had our house painted, but he also had patients over to the house. And kind of as part of his psychotherapeutic practice, and he was a Freudian at first, he just found treat people like people. He was one of the first people to do group therapy. My dad practiced until he was 96, this was just a few years ago. But I was used to seeing his patients at our house. So when I started inviting patients and family to my house, I didn't think anything of it. Artificial barriers. These kids, our kids, the worst part of this psychosis is the isolation. You need a community. You need a community. And that's part of the deal. So, how are we different? I start with philosophy when I get the opportunity. It's very rare. Because, no one jumps and says, oh, I've got this psychotic disorder. I'm going to find Dr. Laitman and find philosophy. That's just not the way it works. It would be nice. I scored about 5%. First time ever, first antipsychotic. It's a small number. Again, the rights. I don't want my kids dying with the rights on. They have the right to be well. Side effects, and I believe most of our kids can get close to their baseline. Really, the earlier you get to them, the better it is, just because there's less damage. You're changing the trajectory of an illness, starting treatment early. But it doesn't mean that you can't succeed starting late. I've started some people as late as their 70s. You got to be extraordinarily careful because side effects are going to be worse in the elderly. You got to go a lot slower. So I am someone who's used it for people with Parkinson's disease. You use incredibly smaller doses, 6.25. Lewy body dementia, I've used it in that setting as well. Again, similar, very low doses, 6.25, 12.5. I don't think I've ever gone over 25. And again, optimism, a sense of optimism as opposed to the nihilism. The belief that you can get people better. Because, again, learn helplessness and hopelessness. You got to combat that the whole time. Again, get to know who you're dealing with. Treat people like people. That's all. I always say the two big things that I expect out of all the people that I've trained and all the people that I work with and myself. And I'm not perfect. We're not all unceasingly kind and we're not all unceasingly competent. But that's what I expect. I expect kindness and competence. And you need, as opposed to incompetence and dramatic unkindness, which is what often the system is provided. Again, I hug. I guess you guys already know that about me. It's not what's typical, and that was also very typical about my dad. There was always this barrier. You sit here, oh, session's up. We're out of here. We're not going to talk. You're going to know nothing about my life. I share my deep, as you know, I share. I think that's really important to connect because when you get down to it, it's all about a therapeutic relationship, right? And also realize you're going to screw up. I'm going to screw up. I'm not perfect. None of us are. We're all going to make mistakes. But I believe in the approach. And I emphasize that. And I never give that up. Sometimes I'm going to say, let's try this. And they'll ask me, has anyone else done? I go, yeah, maybe one or two, or no, you're the first. What do you think? We'll follow you closely, but it's not always perfect. But you, look, these illnesses are different. They're devastating unless you do the work. All my patients have my cell phone number. All of them have my email. When I run my race, we do our races. If you ever see any of the Team Daniel shirts, it's on the back of my shirt. I've actually been approached after a marathon. Someone has memorized my phone number or my email, said, yeah, I was running behind you for about 8 miles. And I got a son, can we talk? So, but it goes a long way. And the belief, your belief, the practitioner's belief is so important. Because you believe it, they'll believe it. That's where the therapeutic relationship comes in. You have to buy in. And I think you will. I was just saying to Dr. Ash last night, I said, the biggest predictor of using clozapine is using clozapine. So people that get used to using clozapine use a lot of clozapine, despite its difficulties, we'll talk more about that as we go into this a little more. It just works better. And there it is, do the work. And it's a long list. So I'm going to, again, full disclosure, I have some ownership interest in Myogenes. I gave them $75,000. I don't know what that bought me. But they're also the ones developing the implant. That's what I'm most interested in. But they do have a genetic test that is somewhat useful. And I think at the beginning of the treatment, it's kind of nice because it'll predict what the odds are, because you can predict how successful the clozapine will be in a given person, just based on a few of the genetics. It's not absolute. The low end of the stick is 20% response rate. The high end is in the high 90s. So it's kind of nice when you get the high 90s. But you know what? 20% is still, at minimum, 3 times as good as the next drug out there. Daniel, when we did the test, 22% response rate. So again, it's not absolute. But it also gives you benign ethnic neutropenia. And if you're a person of color, about 30 to 40% will have benign ethnic neutropenia. So clozapine has been a drug that's been absolutely not used in the population of color because you guys start with too low of a white count. So it has been restricted. The reality is, if you do have benign ethnic neutropenia, you have less of a chance of developing the severe neutropenia. So it's important to identify that, and then the standard is you can start clozapine down to a white count of 1,000. And these are now only guidelines. If you're me, I've started people with white counts below 1,000. I've done the Myogenes test, they were banned, I wasn't worried about it. The severe neutropenia is very distinctive. So it really drops like a rock, and we'll talk a little more about that. And then it also gives you its metabolism and the absolute risk of APRAC. Because there is a certain cohort, like I mentioned with the Finnish population, that had about a 10-15% risk of developing severe neutropenia, as opposed to what we realize now with the best study from David Taylor's group, 3,400 people, first 18 weeks is 0.23%. So in other words, 99.8% will not. And David also said he went up too fast in those patients. So it's less than that. Also, as I mentioned before, I follow THC levels. I do urine tox screens. I'm always after alcohol. I'm always after smoking. These are things, and I monitor them. And you've got to follow metabolic functions. And as I said, the HSCRP is very, very useful. Again, a little old, these slides. This is data from 2022, and this is our breakdown. As you can see, not everyone has a schizophrenia diagnosis. But as I said, I like to think of these things as psychotic spectrum disorders. And some of the others are, we had some people with borderline personality disorder and substance abuse. And it really was clearly, and that I would say it was cannabis-induced. Again, a lot came to us, failures on clozapine, so about half did and half restarted. This is how I like to talk about recovery. Another big mistake psychiatry makes on a whole is trying to get to absence of symptoms. That's what they consider recovery. Another time, bullshit. Daniel hears voices every day. The only time they're completely silent is this one on stage. You can't get rid of all of the symptoms. What you can do is get them well enough so that they can manage the symptoms and manage them well and recognize what they are. Because again, there's so many different permutations of these illnesses. There's so many sensory issues. Don't get bent out of shape if it has a little bit more voices one day, or the voices go away and they come back. It's how he manages them. This is what we're shooting for. We want meaningful activity. I want these people socially engaged back into society. Now, what have we been told? Sustained remission and recovery is not the norm. And that's the best literature in the United States. It's at 14%. New Zealand did better, but again, that's Dan Siskin and Wheeler is out there as well, and they used a lot of clozapine, 33% of their population was clozapine, so they did better. When people came to us, even though we had already 50% almost on clozapine, we only had a 26%. After a year, we're up over 70% recovery. You can do that. They were back in society. And that's what I mean by recovery. Not absence of symptoms. Meaningful interactions, out in the world, having families, having jobs. I have my own little John Nash. I had a kid who was on an antipsychotic for a good 10 years, developed hard eye. I used that as an opportunity. I could have just put him on what's called a VMAT2 inhibitor and kept him on his drug because he was doing all right. But he was also 8 years into his PhD, which he just couldn't get it done. So I said, what do you think? Can we try this? And he was also closing in on 400 pounds. What do you think? I think we can do better. And I switched him over to clozapine. He's 180 pounds, professor now at City College after finishing his PhD in advanced math. So, that's what I call recovery. Daniel getting on stage, doing something that he loves, getting married, that's what I call recovery. Okay? People doing something. The guy I was telling you about, my friend Max, my first AOT, who took me 10 years, who was a music savant, was in all the advanced music schools for guitar, who had stopped playing. Now working, teaching music, living his life. That's what I call recovery. Hospitalizations. You guys have seen the revolving door, right? In and out of the emergency room. Fully, more than 9 out of 10 of the kids coming into our practice, even the ones on clozapine, because they were not being treated appropriately, had been in the hospital coming to me. And I'm sure that, again, you have to realize this is a biased sample. They're coming to me because they're not doing well. So for all full disclosure, and my numbers are really good because I have incredibly devoted parents. And I'm probably on the extreme side of things, though. What I propose is things that can be done elsewhere, and that sounds like you guys are doing so much of what I'm already doing. After 15% in the hospital, and only half of those for, relations because of the actual mental illness. A lot is side effect management, pneumonia, and severe constipation, which I've gotten better with. By the way, do you know what the literature is to scare you? It's to scare you with pneumonia. In the literature, so there's a claustrophobia that revolves around the neutropenia, right? That's what everyone's afraid of. That, if you're going to go for 10 leading causes of death related to clozapine, it's not even in the top 10. It's total BS, and thank God the FDA got rid of the mandatory monitoring. But what is severe constipation leading to obstruction and pneumonia. In the literature, the risk of death with pneumonia is 20%. I've had over 30 pneumonias. What do you think my incidence of death is? 0. Why? Because I understand the drug. You need to be competent when you're using this drug. It is, without question, the safest drug out there to manage a psychotic disorder, if you know what you're doing. If you don't know what you're doing, it's the most dangerous. And that's what's happened. If you have pneumonia, you have to drop the dose. They will get intoxicated otherwise. And that's what we do. We drop the dose. I have a kid right now with horrible flu, fever, chills, and his HSCRP went from 8 to 30. I just dropped his dose to a third. I'd much rather have a live psychotic individual and, overshoot what I need to get them down than to let someone be intoxicated and not be able to clear secretions. So again, and I've had some seizures. I was also early on when I learned that, if I'm really going to use high levels, I have to respect that. More on that. Weight gain. It ain't inevitable. And let me show you this. This is a slide I just added. Oh yeah, got it in there, good. So, a lot of our kids come to us with eating disorders. They, the body dysmorphia, the belief that, they are really very heavy and they restrict. Those kids I let gain weight initially. But if you look at my overweight population, like my little John Nash fellow, they lose weight and it's dramatic. And it's only gotten better because the last 5 years or so, I've been using them for 5 years now. Because again, this is data. You can see, let me see when 2020, right? Yeah, about when we started. And this is, again, a little old, but it's even better. So when I started out, 3/4 of my population was obese. I would say it's about 1/4 of my population now, because they continue to lose weight. There's a guy by the name of Roger McIntyre who does a lot of work on the GLP-1s. So not only is it good for weight loss, it looks like it is something else, another tool that can help repair the brain. Anything that will improve your metabolic health will also improve the metabolic health of your nervous system. Things work better, you think better, you are better. So that also brings me in, I'm just starting to explore Palmer and this guy Matthew Bernstein with Ellenhorn and Accord with their keto diet. There is something about it. It's just I'm really early into that. Again, it could be a tool. You just have to be really careful. And you really talk about really knowing what you're doing. You need a trained dietitian to do that. But obesity is not a thing. It's just Daniel, I think he peaked at around 170. And my son, as you'll see, is not exactly a giant of a man. He's about 5'6", I would say. And now he's 135. Substance abuse? We've been pretty good. We only had 50%, but again, I already had a good number of people on phosphine. And we've really reduced that dramatically. And I emphasize that because every time you use cannabis, you are irreversibly changing another gene. So it's kind of like when you smoke another cigarette, you're adding to your risk of cancer with every single cigarette. Same thing as you keep going with whatever cannabis you have. And I believe in risk reduction. So kids that are down to smoking once a month, I applaud them, but I still say that's still too much. And, we've gotten to the point where we only have just a few kids that are still hanging on and smoking. Same thing with cigarettes. Even tougher than pot. But again, if you look at the general population, there's something to be said for kids being a little thought disordered and concrete if you just keep emphasizing and structuring it right. I don't care if they use a little nicotine. So I do nicotine replacement. I do something called varenicline, which is what's called a nicotine partial agonist. And these things really do work, and bupropion and all stuff. This is a cool slide, but it's just a cool slide. There's only 14 patients. But I have it here just to demonstrate the possibility. And this is just me running out of time. And we started to do the surveys and then I stopped because everyone's busy with life. So kids starting out were pretty good. So this is what's called a global assessment of function score. Basically, it goes to 100, and there is no one at 100. I always like to say Michelle Obama is well into her 90s, brilliant. People are attracted to her. She listens, she's magnetic. She really has it on the ball, and everything is golden. 80 is not bad, though. A person with an 80 is out there, may have a little anxiety. There's maybe some issues, maybe seeing a therapist, but is functioning and is certainly out in society. Afterwards, untreated, a 19, these are kids that are not having any function, often are actively suicidal. They're very, very ill, very detached from reality, not quite catatonic, which scores less than 10, but very, very non-functional. You treat them with a typical D2 blocker. They get dramatically better. They double function. But it's only 38. What is 38? These are the kids in your basement playing video games. They're not suicidal, they're not homicidal, but they're not functioning. People coming in on a previous clozapine regimen were starting to get better. They were starting to get to society. They were starting to work, but they still had significant struggles. 2 years later, 3 years later, or longer, they're close to baseline. That's my goal. Daniel, interestingly enough, is functioning better now than before he became ill, because he had a very long prodrome, and he's also been on this drug 18 years. I have people now that are been on this drug since 1990 that are part of my practice. I wasn't taking care of them, obviously, the whole time, but so. And the thing is, about clozapine, it's easier and easier, and the benefits accrue. What is very typical, and you'll hear this story, oh, it worked so well in the beginning. And we don't know why these drugs, quote unquote, stop working. The thought is dopamine supersensitivity, where basically your body develops new homeostasis, and it gets more receptors, and the D2 blockade just becomes less. Just there's too much D2 in the system, and they decline. That's nothing that happens. And again, that's just a theoretical mechanism. We know that the D2 blockers don't help cognitive negative symptoms, and the natural course is towards decline. We also know long-term that people live longer with clozapine. Again, I'm going to turn to my Finnish people. So if you're looking at 20 years, if you're not on an antipsychotic and you have psychotic disorder, you have a 46% mortality, almost 1 in 2. And these are 20-year-olds talking about being 40. So there's a lot of suicide, there's a lot of accidental death, but they die. Any other antipsychotic like clozapine, we're losing over a quarter of that population. Clozapine, it's not perfect. Nothing is. But it's only 15.8, so it's about 1 in 7. That's the difference. And I've lost a few. I've lost 2 from suicide over the years. And I lost, does my 93-year-old count? She died of old age. So those would be 3 deaths in the population. But this, again, it's a 90% reduction. It's a numbers game. And, I love being a nephrologist, but I'll tell you right now, this has been the single most satisfying thing that I've ever done as a physician. Probably as a person, because I identify myself as a doctor before I even identify myself to my children's and wife's angst as a parent and as a husband, and maybe even a runner in there, but I try to put that behind those other kids. But it really is great. But it's such hard work, and there's heartache because it's not perfect. There's nothing perfect. But what I'm telling you, there's nothing even remotely close to it as good. Nothing even remote. You don't get numbers like this. I don't care what you're looking at with anything else. So these are the realities, the big 7 C's, right? It's a brain disease. It's a lot of people. If you take all comers, it's over 3% of the population. And again, it is cognition. That's really what gets these people. 340 billion. We're doing a study with Schizophrenia and Psychosis Action Alliance, a guy by the name of Tim Murphy. Ever hear of the CARES Act? That was, it was really diluted down. It was so diluted. I saw the original act. We lost so much of that, but whatever we got was helpful, but certainly there's no parity with serious mental illness. We know that. But he's doing another study on cost, and it's well over $500 billion. So. And as I said, people lose their life to these illnesses. And again, we have to think of it differently. It used to be, and this is why I hate the false dichotomy of behavioral health and physical health. It's your frickin' brain. It's attached to your body. It's physical health all over. It just happens to be your brain. So we have to rethink it in that regard. And we have to start at the beginning. Because we can now identify clinical high-risk individuals. And they're doing this already in Australia, where they're taking kids out that are at the higher risk, putting them in classes, following them. There's some work being done on Long Island, where they're taking also clinical high-risk kids and working on processing speed early. The preliminary, and this is preliminary data, we see some of this presented in Florence this March, on my wife's birthday. It actually is her birthday, but it's not why they're presenting it. But, and I already know some of the data, and the data looks really good. We can change the trajectory. The problem is, these are 8-10-year studies. We can start with pregnancy. There's a guy by the name of Friedman from, come on guys, University of Colorado, right here, who looked back at kids that went on to develop psychotic illnesses and looked at old films and saw this clumsiness and all the rest. And said, there's something here. And we already have talked about nicotinic receptors, so we started to supplement in pregnancies with lecithin. And we're starting to see the kids coming out now at 8, 9, 10 years. And there's less of those prodromal symptoms. Will it mean less people going on to psychotic illnesses? We don't know. But it's very hopeful. So we have to realize they begin really early, and there's a huge disconnect from what we know and what we do. And that's why I'm here. And we got a lot of potential, right? A lot of people out there we can help. There's a lot of homeless. These are really old numbers. The numbers are worse. The last homeless count, I think it did broach over 200,000, and the inmates are definitely over 400,000 with SMI in the prison system. And the suicides are, there's just no reason for this. We can really impact it. And what also drives me a little nuts in the mental health community is getting away from, this is my big beef with NAMI, about 10 years ago. DJ Jaffe, anyone know DJ Jaffe?
Books, yeah.
Yeah, Insane Consequences. So DJ, myself, Laura Pagliano, you might know, she's out in Maryland, and I forget, there was 2 more, ran on the SMI ticket for NAMI because we felt the National Board was getting away from their messaging.
Mm-hmm.
And they campaigned against us, against all the rest, and have gotten away from the approach. Because what we would say is, untreated, especially if there's drugs involved, these kids are really violent. They go, no, SMI does not cause violence. But that's just not what the data shows. And we wanted them to focus on SMI. It's great to have anxiety and all the rest, but that's what MHA is for. Hope no one's here from MHA. NAMI was meant, you know the story, it was formed by a group of women with kids with psychotic disorders. And I think it's drifting further from the message, and that's a problem. It's very funny when I go to the conference and they know exactly what I'm going to say with pretty much any talk. The end of questioning always stops with me. It's happened to me 3 times now at the national conference. I get up to the mic, say, that's the end of the questioning. So they're very interesting, and this is hopefully not me being paranoid. But again, if you think about the population being 3%, 10% of the homicides are from people with serious mental illness. And where is the violence often directed?
Family.
You got it, and that's why it's 29% of the homicide for family. Mass shootings, 50%. Probably higher because we often don't know, to be honest. So this is part 1, by the way. This is like a marathon. How's my time?
10 minutes.
10 minutes, so the rest is 15. Yeah, I really did take my time. It's really broken. We can do better. And how do we do that? These are the takeaways from this part of the talk. We're going to whip through this because really this is all in the book, and you're not going to absorb a lot of the slides. I'm just putting them up there, the rest of this, because I just want to show you that we've worked out so many of the approaches to manage these side effects. Okay? We can do better. And my wife's approach, our approach, because other people have been doing this. You talk to Nusafora at Hopkins. There's not a lot of room between us. I talked to Rocco Murata at Silver Hill, Connecticut. Other people have been doing these approach. We just gave it a name. Where do we start? We changed it. Volume 5, get it? Volume 4. I think my section was 70 pages. It's now about triple that, 200, 250 pages. And it's got all the slides so they can actually look at this. And it takes you through the rationale of why we're doing what we're doing. It's written much better because I wrote it with one of my parents, who is a hell of a lot better writer than I am. Cosby Handbook is useful, and there's a lot of synergism between the books. And where we disagree, he's wrong and I'm right. A big problem that we had, Ann and I had, is capacity. And that's been the biggest thing. Capacity, how do you expand the model? Because as you know, there's no parity in mental health. It's incredibly expensive. People spend thousands, tens of thousands, hundreds of thousands of dollars on floor care. 3 years ago, 2 people that have been involved in mental health care working for Athena Health and Firefly, CFO and a CTO, but with loved ones with serious mental illness. A cold approached me, said, we saw your literature, we've read your EASE paper in schizophrenia research. Your data is better than anyone else's. Can we find a way to take your approaches and bring it to the masses? And that was the start of Dora Mind. Dora is, the name derives from Dorothea Dix. Everyone know who Dorothea Dix is?
Yep.
So that was when sanatoriums were really sanatoriums, places of recovery and rejuvenation. At one point in New Jersey, the largest part of their budget was to provide care at sanatoriums.
Wow.
Sure. That's why it disappeared. It was too expensive. And that's why they declined, and that's why they became hellholes, and that's why in the 1950s, when Thorazine came out, we started to deinstitutionalize, and in the 60s, his last act of Kennedy was to start the community health centers, which then got defunded by, we won't mention names because I don't want to get into politics, and That's where we are. So we don't have a model. So Doramine, and we launched April of 23. We now have over 100 patients. We are in all 50 states, 2 countries. We are based on that I am their medical director, and I guide through nurse practitioners and doctors of nurse practitioners. That's the model. So if a PA comes in as a doctor, we're looking for a cost model. And we are, so access, availability is one. The other problem is cost. We are approaching healthcare plans, and I have a huge advantage in that I take care of someone who's director of one of the healthcare plans in New York, whose kid obviously was saved from clostridium, and he's making 7 figures, and having a pretty good life when he pays attention. But nevertheless, she's very grateful, so we're looking to get insurances involved as well. But you can connect with them, so the model is you can connect with them at any time, because that was part of what we did. You know, the only time you can't get a hold of me is when I'm running and sleeping, basically. And it comes up. You need that level of support. And Claire is from England, so she has a great British accent for your Anglophiles like me. Hannah is the most experienced. Stephanie's a PhD. And that's me. So, oops, there we go. So as I said, care, where we do everything, is very regional right now, because NPs, it's about licensing and their ability to write prescriptions. As my patients, because I've kind of integrated all my practice, I'm starting to change them over to DuraCare because I'm looking for them to be my legacy, because I'm 68 years old, and I was also wondering what the hell's going to happen. I have no plans of retiring anytime soon. I still have very much of a mission, but I needed something to carry forward. They're my legacy. And so between their new patient and my patient, I said we're well over 100 active patients there. I still have my 150 that have been reluctant to go over there because a lot of them I actually take care of for free. So I can understand their reluctance. But we can provide care in those states. Compass is consultative. And why I think you could use us and why it would be useful to. And we've set this up. We've lost so much money so far. Thank God that we have angel investors, because we do a lot of free work. Because we're just showing that the model works. And then we have DuraCoach, which is a model that we originally were developing with Javier and Amador, and we backed out. Then we developed our own model, where it'll take you through, reflective listening, cognitive behavioral therapy. It'll do a little cognitive enhancement training for you with your kid, and it's just, it's a pretty small stipend to pay, and it's available, and it works pretty well. So why do you need us? Because it's really complicated, as I said. And I just wanted to take you through this. This is the stuff I just added to the talk. And it's predictable. There are predictable side effects. You shouldn't let it happen. I start with constipation because it's universal. Your gut slows down. Normal transit time in the gut is 24 hours. With clozapine, with no treatment, it's 100 hours. And what's also problematic is the anosognosia, the unawareness. Are you going to the bathroom? Yep. How often? Yep, going. It's all good. So I have all my kids look at it, and I have it on my desk, a Bristol stool chart. And even when I'm on Zoom, I'll put it up to the thing and say, so what does your, excuse my language, shit look like? Is it like that? Is it every day? And I'm very precise about it. Because they'll tell you about diarrhea, but they won't tell you if they're on one every 3 days. But that's not a problem. That is a problem. Because if you don't treat it, and you're 4 or 5 years out, you have upwards of a 15% chance of obstruction. It's just not good to have a gut that is that slow. But it's easy. It's Colace, stool softener. It's a laxative. It's a little Miralax. It's not expensive. If you really need them, you use some of the Secretods that are out there. There's not one kid, I should say, there was one kid, one of my admissions, but that's because he wouldn't take anything. And his dyssynergia was severe. And he had a deep disaffection. I've had one manual disaffection. I've had no obstruction. So it's very, very treatable. But it's a lot of work. And you have to constantly be vigilant. Then I go to the second big problem, which is the risk for pneumonia. It happens. I push levels. It's going to happen. But you can treat the sinuria. Daniel, 6 months into treatment, had a 6-centimeter abscess in his lung. We didn't know better. Ann and I, being who we are, 28 days of IV ceftriaxone with an IV every day, didn't miss a day of school. We ran in 2 grams. Don't you do this with every breakfast? 2 grams of IV ceftriaxone. Delicious and nutritious. And we got rid of his abscess and learned you damn well better pay attention to the sinuria. So you do. You put the head of the bed up. There are topical agents you can put on. You can use, again, so the sinuria, it's interesting. Clozapine is anticholinergic, but its major metabolite is norclozapine, and that is very cholinergic, and it stimulates excessive salivation. And the problem is at night, especially early on when they tend to be excessively sedated, there's pooling in the back of their throat. So they'll choke. Don't let it happen. You can either squirt the damn topical agent under their tongue, or one of the tricks that I just came up with recently, because some of the kids really hate that, is I have them gargle. I squirt 4 puffs of the ipratropium nasal spray, or take 4 drops of atropine eye drop, put it in 2 ounces of water, and have them gargle it. And it kind of coats all the members and then spit it out. So they don't get any of the other anticholinergics. They actually don't swallow it. That works pretty well. Glycopyrrolate works great. The problem is it's anticholinergic. So if you're going to take care of the sinuria, 5 minutes? Okay, I'll quit. You know, it doesn't cross the blood-brain barrier, but causes constipation. Now, if you're lucky and you have someone who is a good ear, nose, and throat doctor, or is someone who treats Parkinson's patients, because they have a lot of trouble with sinuria, with excessive salivation as well, you have them do botulinum injections, and that's every 3 months. And you start low and you build it up, and that really works great. Weight gain, I think we already demonstrated that. That should not be a problem. Have a brain. Don't be afraid of medicine. The only thing about metformin is, one, it's also neuroprotective. And I've been on metformin forever for that reason. And GLP-1s, again, clozapine, because it is antihistaminic, and it is anticholinergic, as anti-serotonergic product, does cause an increased appetite. You have to work at this. But you have tools. You don't have to accept any of these things. You saw our average weight losses. That's not unusual. It's only better. Pay attention. Weigh them every single time you see them. Check their blood pressure. Check their pulse. Seizure risk. I tend to get the resistance of the resistance. So where I told you my numbers are really good because I have so many people that are so invested in all this, but my numbers shouldn't be that good because I also have the resistant clozapine patients, and yet they're really good. But that means I push levels. If you're pushing levels, part of clozapine's mechanism is it lowers the seizure threshold. This is where we disagree with clozapine handler. I start lamotrigine early. It's well tolerated, and when people were asked what drug would they least like to give up if they were taking, of all the drugs, antidepressants, anti-seizure medicines, mood stabilizers, antipsychotics, lamotrigine. People, it tends to stabilize mood, gently lifting it, but it's also pretty effective as seizure prophylaxis. Cardiac issues. A handy surrogate for increasing levels of clozapine is the heart rate goes up. Remember, it's anticholinergic. It's also blocks alpha 2, so it tends to cause relaxation of the blood vessels, so the blood pressure falls. When the blood pressure falls, you need to increase your cardiac output so you increase your heart rate. Easy to combat. And it's not nice to leave someone with a very fast heart rate because also people are aware of that. They have that sense of self. If you've ever had your heart racing, it's a very uncomfortable feeling and it leads to a lot of anxiety. So we use beta blockers really judiciously. In the beginning, when I'm really just trying to get control over the positive symptoms, I tend to use beta blockers that cross the blood-brain barrier. Again, different from what is in the clozapine handbook. So I'll use typically metoprolol, which is beta-1 selective, so that you don't involve the lungs, or I'll just use propranolol, which is less selective, probably the most effective in terms of the anxiety and the heart rate. Once the positive symptoms are well controlled and you're working on cognition, I'll often switch to something that does not cross the blood-brain barrier, and I typically use atenolol. And that works really great. And again, there's no reason to accept a fast heart rate. Cardiomyopathy is one of those late complications. Shouldn't happen. Never seen it. Hope never to see it. Stuff they won't tell you unless you ask. Right. Bedwetting. It's a big issue. It's just part of the way clozapine interacts because it doesn't only interact with all these transmitters in the brain, it does it in the bladder. So the bladder, you have a sense of fullness earlier and you don't have as good a control and you're sedated. So one of the tricks is one, stop your coffee, which is really tough because coffee is so good for attention, but coffee really, if you drink coffee, and I do, as you notice I'm in the bathroom a fair amount, it really gets you going. And also you do tricks. You keep them away from their fluids the last 2 hours. But one of my neat tricks, being a nephrologist, is I have them make less urine at night. And so the oral formulation is better than the intranasal because it's got a very short half-life. So you say, oh my goodness, aren't you worried about psychogenic polydipsia? Well, the treatment for psychogenic polydipsia is, anyone? Clozapine, that's correct. So it's very unusual. In fact, often most of our kids don't drink enough.
Right.
So you could get away with giving a little DDAP that's about 8 hours, and how long are they usually sleeping? Our clozapine families? Longer than 8, 10 to 12. So it's not a big deal, and it dramatically decreases. It gives them such a feeling, because it's such a bad feeling to wake up wet when you're 25 years old, especially if you're in a relationship with someone. So just a little dose of DDAVP, and I've done as high as 0.4, but you have to pay attention. I have made one person I've been treated with that. So 0.1, never. Not a problem. Okay. Sexual function. There is retrograde ejaculation, but it doesn't affect sexual potency. There's no effect on prolactin, as I said, so sexual function is pretty good. Sedation is a bitch. Yeah. Sedation, in other words, being knocked out and having to sleep for 12 hours. That's something that's fairly constant. The best thing that I've seen for that is fitness. If they exercise, they get better. There are a lot of tricks, but all these tricks come with a price. They start to work on dopamine, so when you're dealing with alertness, except for maybe the modafinils, which we now know work on orexin systems as well as dopamine, but they all can make you psychotic. So you have to be very careful when you're introducing these things. Catatonia is an issue for these people. For clozapine, along with obviously benzodiazepines and ECT. Really quick. And then this big bad boy, neutropenia. Again, bullshit. It is less of a concern. We still recommend doing the blood count for the first 18 weeks because there is that. That's when the risk is. It is less than 0.23%. It is a tiny risk, but it is a risk. Having said that, totally unofficially on my part, and I leave this up to your best judgment, because it is now up to the best judgment of the physician. I can get away with this because I'm considered expert. I do not hold my patients to every week. I write 30 days in the beginning. The worst thing you can do is run out of clozapine because they didn't do a blood count. That's silliness. That is not looking at risk and benefit. I do everything that I do, risk and benefit. The benefits are huge, the risk is minimal. There is a device called the Atlas device. I have no ownership interest in that. It's a finger stick device and it does make it a little easier. You can look that up. I think Golden Gate Pharmacy is first. So again, as we talked about a little bit, you can try to wake people up, but it comes with a price. And these are all the things, except for obviously using socialization, family therapy. And what do you do when nothing works and they're not responding? Another underutilized treatment. Electroconvulsive therapy, bifrontal. I need to change the slide. It's as effective as bitemporal with less side effects and much more effective than right unilateral. Don't even start with right unilateral. It doesn't make sense. The bifrontal is that much more effective. There is a response rate in the 60-70% range, and it's very operator dependent. And you have to get rid of the lamotrigine and that side. It's all about the seizure. It's incredibly safe. It's incredibly effective. There's some short-term memory loss, it's true. But long-term memory actually improves. Working memory improves. ECT, like clozapine, like lithium, you have three amazing treatment modalities underutilized. Oops. Oh, where did I go? Oh. And then I said consider fluvoxamine. This is my neat little trick, and it was pretty prominently talked about in the first book, and I still do it. But when you're starting out with clozapine, I really caution you not to, because you really have to be good at clozapine before you do this. Because if you do it incorrectly, the levels are going to shoot up before you know it. Having said that, if you're really comfortable with clozapine and you have access to therapeutic drug monitoring, and the kid's not responsive, what we found is you can push clozapine levels up, because that's the active antipsychotic. It's not the norclozapine, though the clozapine and the norclozapine both contribute to the side effects. So what you do is you can change the ratio, and doing that, you can explore 1100, 1200, 1300. Get experience, get your compass involved, until you really know what you're doing. I did not do this for many years. But now I have probably 80 kids on this combination. And start slowly and measure levels after every dose. I've had people just say, oh, fluvo, easy, I'll put them on 50. The kid's in the hospital with a seizure. You can't be silly about it. Again, it's the safest drug if you do it right, the most dangerous drug if you do it wrong. I just have to put this in. Exercise. If you want a magic bullet, it's that. And socialization. We, to this day, for the last 6 years, every Saturday we've either Zoom, we have a 3-hour Zoom, which you guys can sign up for. I'll give you the contact information. Or we just go through and we talk you through questions, and that's just 11 to 2 Eastern Standard Time. Except for during season where my pool's open, and then we do it every other week, because then I have kids to the house, and we run. And Daniel does a kids Zoom after the 11 to 2, and then it runs from 2 to 4, usually, on Saturday. There's the studies. They keep studying exercise. They're always positive. They're always good. And I just want to show you this. It is really, when you get down to it, clozapine is the ultimate teamwork. It's really a team drug. The two kids there, well, the first guy is my good friend and also the commissioner of mental health. So he's been running with us for the last 8 years. And Jasper just ran a 3 hours and 49-second marathon. And Maliki, the kid on the end, just ran a 3:16. He's going to blow through the 3 hours because he was ranked 7th in New York State before he got sick. He peaked out. That little guy there, he's about 150 something now, he peaked out came to me at 250 pounds. I'm done. That's what people say. If you believe it, it's really true. It quiets your mind. Kids look normal. And remember, we're such a tribal And we're not that far, we're so tribal, and we're so, not far removed from our Paleolithic era. You gotta look normal. If you don't look normal, you're banned from the tribe. Kids on clozapine look and act normal. And better and better. Takeaway. So what is the big takeaway? Don't buy it. People can get better. And there is no easy solution, but there is a solution. So there's contact for Duramind if you want it. And this is my contact. And now I'm done.